Namaste बिटिया, हमेशा खुश रहो बिटिया. A very good morning to you all. Myself, JVN Dr. Ravi Jain, Assistant Professor, Department of Practice of Medicine in Faculty of Homeopathic Science at JAYOTI VIDYAPEETH Women's University, Jaipur. In today's lecture, we are going to discuss about a new topic of the locomotor system, that is ankylosing spondylitis. In the last lectures, we had discussed about osteoarthritis, and we had also discussed about rheumatoid arthritis. I hope the things have been clear to you. Both these topics are very important from the examination point of view because we get a question on this particular topic every year. Now today, let's start with a new topic, that is ankylosing spondylitis, or it is also known as the bamboo spine. What is ankylosing spondylitis? What is the etiopathogenesis? What are the various clinical features, the signs and symptoms with which the patient can present to you? What are the various investigations that could be done in such case? And how to manage a case of ankylosing spondylitis? All these things we are going to study today. Ankylosing spondylitis, it is an inflammatory disorder of unknown cause that primarily affects the axial skeleton. So the axial skeleton is affected. Axial means the central skeleton is getting affected. So it is the inflammatory disorder of unknown cause, means we do not know the cause for this particular disease, that primarily affects the axial skeleton, the peripheral joints, and the extra-articular structures. So not only the axial skeleton is getting affected, but the other things that are affected are the peripheral joints and the extra-articular structure, as we have seen in case of rheumatoid arthritis, where the extra-articular surfaces were also getting affected. It is a chronic inflammatory arthritis in which that predominantly affects the sacroiliac joints and the spine, which can progress to the bony fusion of the spine. All right, so it is a chronic inflammatory arthritis. Chronic inflammation is there, and arthritis because it is affecting the joints, and it predominantly affects the sacroiliac joints and the spine, which can progress to the bony fusion of the spine. There are different types of spondyloarthritis, or we are also known as AKS spondyloarthropathies, in which one we have the axial spondyloarthritis, where the central or the axial skeleton is getting affected. The symptoms includes the chest, spine, and hip bone. And next we have the peripheral spondyloarthritis, in which the peripheries are getting affected. Peripheries like the fingers, the knees, and the toes. So these are two types of spondyloarthritis, axial and the peripheral. Axial, which have the symptoms of axial joints like chest, spine, and hip bone, and the peripheral, which includes the fingers, knees, and the toes. Now, ankylosing spondylitis belongs to the family of spondyloarthritis. All right, so it belongs to the family of spondyloarthritis. Spondy means related to the spine, and arthritis. Spondyloarthritis also includes, number one, we have reactive arthritis. Next, we have psoriatic arthritis. Other, we have enterohepatic arthritis, enteropathic arthritis. Next, we have juvenile onset spondyloarthritis. And next is undifferentiated spondyloarthritis. So, spondyloarthritis includes reactive arthritis, psoriatic arthritis, enterohepatic arthritis, juvenile onset spondyloarthritis, and undifferentiated spondyloarthritis. Now, this was the classification of spondyloarthritis. Now we come to ankylosing spondylitis, the etiology and the epidemiology. So, ankylosing spondylitis, it usually begins in the second or third decade, means 11 to 30s. So, in the second decade, that is 11 to 20, and third decade, 21 to 30. This is the common age group in which we are seeing ankylosing spondylitis. The male to female prevalence is between 2:1 and 3:1. So it is more common in male as comparison to females. 2 to 3 times more common in males than females. It's commonly known as the axial spondyloarthritis. It has association with HLA-B27 antigen. As we have seen in case of rheumatoid arthritis, it was HLA-DR4. In case of ankylosing spondylitis, it is having HLA-B27. More common in males. Now, what is the pathology? The pathology of involvement of ankylosing spondylitis. It is having sacroiliitis. It is the first often the earliest manifestation, inflammation of the sacrum and the ilium, that is known as sacroiliitis. It is the earliest manifestation. The knowledge of its pathology comes from the biopsy and autopsy studies. This is inflammatory granulation tissue in the paravertebral connective tissue at the junction of annulus, fibrosis, and vertebral bone. The outer annular fibroses are eroded and eventually replaced by the bone, forming the beginning of syndesmophyte. The syndesmophyte then grows by continual endochondral ossification, ultimately bridging the adjacent vertebral body. So what is happening? First of all, we are going to see sacroiliitis, that is inflammation of the sacrum and the ilium. The knowledge of this pathology comes from both biopsy and autopsy. So the changes that we are going to see in case of spondyloarthritis comes from the biopsy and autopsy studies. It is an inflammatory granulation tissue in which the paravertebral connective tissue in the joints, the junction of annulus, fibrosis, and vertebral bones. I have given the pictures in the presentation that I have shared with you. The outer annulus fibers are eroded and eventually replaced by bone. There is forming the beginning of the syndesmophyte. The syndesmophyte then grows by continued endochondral ossification, ultimately bridging the adjacent vertebral bodies. I have shown you the picture of the vertebral column showing the annulus fibrosis, showing the spinal cord, the transverse process, the spinous processes, and the superior articular facets, and also the nucleus pulposus. Now, in the pathology, there is ascending progression of the processes leads to bamboo spine. So, because of the all these processes involved, there is formation of the bamboo spine, and the other lesions in the spine includes diffuse osteoporosis. We have erosion of vertebral bodies at the disc margins, that is known as squaring or the barreling of the vertebra. There is inflammation and destruction of the disc bone disorders. The inflammatory arthritis of the apophyseal facet joint is common, and there is erosion of the joint cartilage by pannus formation, followed by the bony ankylosis. Inflammation of the fibrocartilage, cartilaginous anthesis takes place. Now, what are the clinical manifestations? Whenever a patient of ankylosing spondylitis is coming to us, what are the clinical features or what are the clinical manifestations that the patient is showing? In the course of disease, it is extremely variable, ranging from the individual with mild stiffness to normal radiographs of the patient with a totally fused spine. So there can be mild symptoms of or mild stiffness in the individual and normal radiograph to the patient with totally fused spine. So there can be mild stiffness to the total fusion of the spine and several bilateral hip arthritis, accompanied by the severe peripheral arthritis and extra-articular manifestations. The constitutional symptoms include fever, fatigue, and weight loss. There are various neurological complications related to the spinal fracture or dislocation. Atlantoaxial subluxation, this can lead to the spinal cord compression and cauda equina syndrome. So we have neurological complication related to the spinal fracture or dislocation. We have atlantoaxial subluxation. This can lead to spinal cord compression and cauda equina syndrome. The symptoms of the disease are usually first noticed in the late adolescent or early adulthood. So we are seeing the symptoms in late adolescence and early adulthood. Initial symptoms include dull pain and insidious in onset. So there is dull pain and the symptoms are insidious or slow in onset that are felt deep in the lower lumbar or gluteal region. It is accompanied by lower back morning stiffness of up to few hours duration that improves with activity and returns following inactivity. Within a few months, the pain becomes persistent and bilateral, and there is nocturnal exacerbation of pain that often forces the patient to rise and move about. So in the clinical manifestation, we see the symptoms are usually seen in the late, because in the second and third decade, late adolescence or early adulthood. The initial symptoms include dull pain or insidious onset of the symptoms, which are felt deep in the lower lumbar or the gluteal region. It is accompanied by low back pain with the morning stiffness and up to a few hours duration that improves with the physical activity and returns following inactivity. Within a few months, the pain becomes persistent and bilateral. There is nocturnal exacerbation of the pain that forces the patient to rise and move about. There is also bony tenderness. Bony tenderness that costochondral junctions, spinous process, iliac crest, general trochanter's, ischial tuberosities, tibial tubercles, and heels may accompany back pain or stiffness. There is hip and shoulder arthritis. It is considered part of the axial skeleton. There is severe isolated hip arthritis or the bonoarthritis. Pain may be the presenting complaint. The arthritis of the peripheral joints other than the hip and shoulders are asymmetrical. So we also see bony tenderness in the costosternal junctions, spinous process, iliac crest, and greater trochanterus. There is ischial tuberosities, tibial tubercle, and heels may accompany the back pain or stiffness. The hip and the shoulder arthritis are considered as part of axial disease. There is severe isolated hip arthritis or the bony chest pain that may be the presenting complaint. Arthritis of the peripheral joints other than the hip and shoulders are asymmetrical. We also see various types of extra-articular findings. Extra-articular findings includes the acute anterior uveitis in up to 40% of the patients. We have aortitis, aortic insufficiencies, GI inflammations, cardiac conduction defects, amyloidosis, bilateral upper lobe pulmonary fibrosis. So in the extra-articular findings, we have acute uveitis in up to 40% of the patient, aortitis, aortic insufficiencies, GI inflammation, cardiac conduction defects, amyloidosis, bilateral upper lobe pulmonary fibrosis. There is also juxta-articular pain due to enthesis, that is inflammation at the insertion of tendon and ligament into the bone, that is frequently affecting the greater trochanter, iliac crest, ischial tuberosity, tibial tubercles, and the heels. Chest pain occurs from the involvement of the thoracic skeleton and muscular insertions. So in the extra-articular findings, we are including the eyes, acute anterior uveitis in 40% of the patient. We have aortitis, inflammation of the aorta, aortic insufficiencies. There are different types of GI inflammations, cardiac conduction defects, amyloidosis, bilateral upper lobe pulmonary fibrosis. There is also juxta-articular pain due to enthesis, that is inflammation at the insertion of tendons and ligaments into the bone. There is frequently affected greater trochanter, iliac crest, ischial tuberosity, ischial tubercle, and the heels. The chest pain occurs from the involvement of the thoracic skeleton and muscular insertion. Now, what are the various physical examinations that we can do in case of ankylosing spondylitis? We are going to see tenderness over the involved joint. So in the involved joint, there is tenderness with diminished chest expansion. So the chest expansion is diminished. There is loss of spinal mobility with limited or of anterior and lateral flexion and extension of the lumbar spine and chest expansion. There is pain in the sacroiliac joint, which may be elicited either with direct pressure or with the stress on the joints. Diminished anterior flexion of the lumbar spine, that is known as Chopard test. So in the physical examination, we are going to see tenderness over the involved joints. There is diminished chest expansion, loss of spinal mobility with limitation of the anterior lateral flexion and extension of the lumbar spine and of the chest expansion. We are also going to see the pain in the sacroiliac joint, which may be elicited either by direct pressure or with stress on the joints. There is diminished anterior flexion of the lumbar spine, that is known as Chopard test. Now, what is Chopard test? Chopard test is a useful measure for the lumbar spine flexion. The patient are asked to stand erect with the heels together, and marks are made on the spine at the lumbosacral junction and 10 centimeter above. So one mark is done at the lumbosacral junction and the other 10 centimeter above it. The patient then bent forward maximally on the knees, fully extended, and the distance increases. So the distance between the two marks are measured. If the distance increases by greater than 5 centimeter in the case of normal mobility, and less than 4 centimeter in case of decreased mobility. So if there is mobility greater than 5 centimeter, it is normal. Now, how to evaluate the case of ankylosing spondylitis? We have to check for ESR and the C-reactive protein. So there will be raised ESR and raised C-reactive protein. There will be mild anemia. There will be rheumatoid factor and anti-nuclear antibodies negative. So ESR and CRP will be raised. Mild anemia will be there with the rheumatoid factor and ANA negative. There will be presence of HLA-B27. It is helpful in patients with inflammatory back symptoms, but negative X-rays. The radiographs early may be normal, and the sacroiliac joints are usually symmetrical. There is bony erosion with pseudo-widening that is followed by fibrosis and ankylosis. Now, what are the differential diagnoses in case of ankylosing spondylitis? The other diseases that resembles ankylosing spondylitis includes osteoarthritis, spondylosis, degenerative disc disease, muscular strain, fibromyalgia, metabolic infectious disease, malignant cause of back pain, and diffuse idiopathic skeletal hyperostosis. Now the treatment. The treatment for ankylosing spondylitis includes the exercise program to maintain posture and mobility. Non-steroidal anti-inflammatory drugs that are the first line treatment. We have TNF modulatory agent to improve the disease activity and reduce the bone marrow edema. We also give secukinumab, and interleukin 17A antagonist has been found to reduce the signs and symptoms. Other drugs include sulfasalazine and methotrexate, that is DMARDs, known as drug-modifying anti-rheumatic drugs. And then intra-articular glucocorticoids can be given. Surgery for the severely affected deformed joints. This is all about ankylosing spondylitis. So I hope you have understood this session properly. Go through this topic once again from the book, and if you have any problem, you can ask me later on. So this session is powered by Digital Version 2.0, JAYOTI VIDYAPEETH Women's University. I hope you have understood the session properly. If you have any query, please mention in the comment box and I'll try to resolve it. So this was all for today. In the next lecture, we will be studying reactive arthritis. Thank you very much.